يعني فوق انك ما تشتغلش كمان تاخذ ماسكه.
International Health Conference for the Jordan. سامعيني الجميع? Everything okay?
صوتك واضح دكتور غيث، تفضل.
Okay, so it gives me great pleasure to participate in this first International Health Conference for the Jordan Healing and Health Bank. So I would like also to take this opportunity in thanking the conference committees. So my presentation will be about bone tumor surgery's King Hussein Medical Center experience.
دكتور غيث.
A second.
Okay.
So I will start with some outlines and objectives. History of orthopedic oncology at King Hussein Medical Center, how we progressed from the past, demonstrating some current concepts and updates, onto a study we performed at King Hussein Medical Center, a retrospective analysis for bone tumors around the knee, some prospects for the future, and some take-home messages that could help in keeping us out of trouble, hopefully. So a quick talk about the history of orthopedic department. Beginning of the 70s, it started as a branch of the Department of General Surgery at the Amman Military Hospital. 1974, it was transferred to King Hussein Medical City. 1980, it became an independent department headed by Dr. Atallah, God bless his soul. And 82, The orthopedic department was moved to the Royal Rehabilitation Center. 1995, Dr. Abu Noor established a 5-year independent orthopedic residency program, ending by the Jordanian Orthopedic Board exam. So as you all know, tumor surgeries started with tumor local excision, which carried high mortality, onto amputation that was shown to decrease the mortality. And now the current concept is limb salvage surgery. So limb salvage surgery basically is resecting the tumor, taking out the tumor whether it was bone or soft tissue, and reconstruction to be done either using bone and bone substitutes or by metalwork, what we call an endoprosthesis. Soft tissue reconstruction is very important to cover our work, whether it was with the remaining healthy muscles or some synthetic implants. This is an example of how we cover using the remaining healthy muscles, or what we call a synthetic mesh, polyester, non-absorbable. An example would be a Lars ligament that can also be used to complete or bridge the soft tissue over the endoprosthesis and augment the work. Progressing, we have improvements in imaging techniques, 3D planning, simulation of operations before they're done, marking the tumor margins, something known as VERTOPS, which is virtual operation planning in orthopedic surgery. This used to be done in open. Sorry?
Technical interruption. كمل دكتور غيث.
Okay. It used to be done by an open method, which carried high morbidity, then to a less morbid procedure, which is done through a core needle biopsy or true cut. This actually lets a wide door open for the future research, whether or not there's something else to be done. As you all know, the most common tumors, malignant tumors of bone, osteosarcoma, Ewing's, chondrosarcs. The invasive benign ones, the most common, or the one that we frequently encounter, is a giant cell tumor. The advantages of the metal endoprosthesis, or what we call modular resection system, would be it gives early stability, early mobilization. It has good functional results, and it can ease the introduction of post-operative adjuvant chemotherapy as soon as possible. This is the study I was talking about. We had a retrospective analysis for 30 patients with tumor around the knee, 27 of which had malignant bone tumors. And after doing the analysis with a 2.5-year follow-up, we found that the survival rate, 5-year survival rate of the 27 patients out of the 30 which had malignant process around their knees was something around 40%. Again, the musculoskeletal functional score was 60. We found that this was going with the international ranges, satisfactory and accepted international ranges for the patients. So the conclusion was that these methods of reconstruction actually did decrease not only the morbidity, also the mortality. This is a chap we had, he was around 27 years old with a proximal humerus pathology. After doing the tumor workup, he was diagnosed as a proximal humerus osteosarcoma. This is the MRI on the left side. Here's the bone scan. And then we proceeded with the tumor resection. This is the extended or modified deltopectoral approach. Of course, we separate the deltoid from the pectoralis from the pec major muscle. And this is the subscap. This is the coracoid process. And down here, we have the short head of biceps with the coracobrachialis. So this shows how we implant the endoprosthesis after taking out the tumor. Neurovascular structures are here evident. This is how it looks on post-op x-rays. This is the mesh I was talking about, the polyester non-absorbable, or proline. It's used to envelope the endoprosthesis and helps in the fibrous on-growth, which gives more stability actually and coverage of the endoprosthesis. This is another example for a distal humerus involving the elbow, also synovial sarcoma. After doing the distal humerus resection with the elbow, I implanted the distal humerus resection system or endoprosthesis, and this is a post-op. This is a post-op video after a year or so regarding the functional outcome. Again, another example. This belonged to a 14-year-old female patient, had a combined distal femur with proximal tibia Ewing sarcoma. which actually is one of the challenging cases because we have to take out the tumor in a extra-articular method. So it's an extra-articular resection, not to contaminate other aspects or neighboring structures. And this is how it looks on X-ray, the distal femur endoprosthesis, the proximal tibia endoprosthesis. And we use some of the remaining healthy muscles to help in coverage of the endoprosthesis, along with the reconstruction of the patellar tendon using the medial head of gastrocnemius to augment the extensor mechanism. This is an example of how that poor performed biopsies could affect actually the morbidity and mortality. So we like to see a less using a lesser of approach to the tumor, so that we can be able to take less amount of tissue of the biopsy tract. When it's like this long and with wide sutures going on, then you have to take the whole area out, which actually causes some challenge in the reconstruction and the oncological outcome. Again, this is an example of the reconstruction. This is the remaining healthy part of the patellar tendon. This is to reconstruct on the proximal tibia prosthesis, and we augment it with the medial head of gastrocnemius. This is how it looks on the post-op X-rays, the proximal tibia resection system. This patient was transferred to us from the West Bank, 21-year-old. Again, you can see how that the drain was exiting from a quite wide distance from the scar of biopsy. And so all this area is contaminated, which means you have to take it out during the surgery. And then you have to have some muscle flaps and grafts, and it affects the morbidity and mortality possibly, as I said. This is her photos post-operatively and an X-ray showing the distal femur modular resection system. This is an example of the all polyethylene. Argument is going on that it actually preserves bone stock in younger age groups. So when you come to the revision surgery, you find more bone to use in the revision surgeries. I personally didn't find that much of a difference in the studies and observations internationally. Another example is a 38-year-old male who had a pathological fracture in the proximal femur. And actually, it's quite difficult to detect some pathology going on when it's in early stages. So a procedure was done of a fixation. And then after some months or a year, we had this tumor growing. And actually, it turned out to be a chondrosarc. So evidently, it was probably in chondroma growing, and then there was malignant transformation. Then you have to take all the metalwork out and the proximal femur, and to reconstruct. This is the photos of the operation, and then reconstruct with a proximal femur modular resection system, also called an endoprosthesis. This is a bipolar version of it. This actually is the version of the proximal femur modular resection system. This patient was 58 and she had a metastasis. She had metastasis to the proximal femur, although the primary site, the breast, was under control, and this was a solitary site of involvement of the proximal femur. So this is an indication of resection and endoprosthesis reconstruction. And this is her post-op X-ray, post-operative clinical video after a year or so from the surgery. This demonstrates a method we use, which is bone transport, actually, whereby after resecting the pathology, whether it was tumor or infection, and you use the proximal tibia part or distal tibia to transport it down to fill in the defect, a concept known as osteogenesis, distraction osteogenesis. And another example would be a distal tibia tumor, a malignant tumor. After doing the resection, a fusion nail, ankle fusion nail, was inserted, and we augmented this with the fibula from the same side and a synthetic graft. And during her follow-up in the clinic, she had a good functional and oncological follow-up. A case demonstrating a 13-year-old with a femur shaft sarcoma, and it was actually for a long distance. So resection was done, and using a non-vascularized fibula to bridge the defect. It was around 15 centimeters with metalwork, and we augmented it with synthetic graft, and this is a post-op X-ray of the patient, and you can always go in again and do further reconstruction work according to the outcome. This is a tibia, again, another example of a tibia shaft resection, diaphyseal, 12-year-old boy with Ewing's sarcoma. Here we used ipsilateral shift and a contralateral fibula, which was vascularized with the help of Dr. Samhar, which is currently the director of the Royal Jordanian Rehabilitation Center, Farah Center at King Hussein Medical City. And again, a resection length of around 15 or so centimeters was reconstructed with an ipsilateral fibula and a contralateral vascularized fibula. And this is how it looks actually after a year or two. It becomes like a tibia. It grows in width and length, and you have good results. Had to take out the proximal screw from here because it caused some irritation. Another case would be the pelvis tumors. This patient actually presented like this, and we took a biopsy. It showed to be a chondrosarc. So it was a long-standing exostosis or benign tumor that transformed, had malignant transformation into a chondrosarc. And we performed for him a type 1 pelvis resection, taking out the ilium. And then you can reconstruct with the remaining soft tissue. And again, we have cooperation with our spine surgeons in having some reconstruction done when you go for sacrectomy. You have to stabilize the pelvis, and we use a connection between the lumbar and the ilium. So actually, we are having a multidisciplinary approach towards oral patients, but sometimes we encounter these difficult, challenging cases that present like this, actually, huge tumors. And this patient turned out to be a malignant process, and she came to us like this, actually. And we believe that the main reason for the difference in survival rates is that more than 50% of our patients present to our service at an advanced stage. So it's an opportunity to have the awareness between the population. And this is a big thank you to the Jordan Healing and Health Bank, which also participates in the awareness for the population in decreasing the mortality and morbidity. We are also having comparison between our old procedures and up-to-date procedures. They're actually comparable with excellent results on both of them. But as the evolution of orthopedic oncology is witnessing in the world, we have to go hand in hand with what's happening. So this is a case of he was an 18-year-old gentleman in 1996, had a proximal humerus resection and reconstruction, biological reconstruction with metalwork. This case was done 1996 by Dr. Abu Nawar, God bless his soul. And this person visited me actually during 2016. He was driving his car coming from up north, Ramtha. He had 4 kids, and he has a good oncological and functional outcome. Comparing to what we're doing these days, we had this patient who was around 28 years old with this proximal humerus tumor, large tumor, presented like this. And we have, this is a bone scan showing and a CT that shows, sorry, a CT, a 3D CT, and that shows the vessels that were near proximity to the tumor. And this is a system we use these days, which is a reverse shoulder modular resection system. So it's the proximal humerus modular resection system engaged with a reverse shoulder. This is how it looks like on X-ray. And post-operative care was arm sling for 4 weeks. Then we started physiotherapy. This is a paper we published also regarding a rare case, chondroblastoma of the third metatarsal bone. Again, resection was done and reconstruction using a fibula. This is how it was on MRI and X-rays, pre-op and post-op. We used wires and to bridge the defect. And this is how it looks after 8 months. The patient also has good functional and oncological outcome. So some prospects for the future to provide state-of-art comprehensive cancer care to people of Jordan and the Middle East in cooperation with other Jordanian organizations and hospitals, of course. Access to education, training the public and the medical staff in how to have early detection of prevention of cancer, which affects the mortality and morbidity, as I said earlier. Research is very important, and we're looking forward to opening doors in cooperation with other institutes to have this wide scale of research, our own research. Some take-home messages, hopefully, that could help keeping us out of trouble. Malignant bone tumors, as you all know, are a major concern, and we should actually start treatment as early as possible. Endoprosthesis should be considered as a treatment of choice for bone tumors. We should always keep in mind the clinical aspect. Communication is of utmost importance. We should be familiar with the updates and not to hesitate to take other people and colleagues' opinions. And a point that I always stress is that we accept a less functional outcome on the account of decreased morbidity and mortality rate, so life before limb. We have to be familiar with all implants, techniques, and sophisticated updates and the indications. And a very important message, actually, that all techniques are not out. We have good results that go back to the 90s and 80s, functionally and oncologically. So all techniques are still being used with good results, and we have to keep this in mind, especially when it comes to cost effectiveness. And we should always keep a learning attitude for other teachers and the results. I would like to thank you all for your time, and I hope this presentation was of benefit to all of you.
شكرا دكتور غيث، يعطيك العافية سيدي.
الله يعافيك دكتور غاندي، شكرا لك.
شكرا. Thank you for this nice lecture and for the historical point of view, for the preparation of the tumor surgery and the regular medical services, and of course God bless all of the senior doctors. One of them, of course, Dr. Abdelkarim Abu Nuwar. Now our next speaker, دكتور عبد الله الخوالدة. دكتور عبد الله الخوالدة رائد طبيب في الخدمات الطبية الملكية، أخصائي أول جراحة العظام والمفاصل, foot and ankle surgeon. He is one of the senior orthopedic surgeon real medical services. He will be talking about mid-foot the dislocations, assessment and management. تفضل دكتور عبد الله.
يعطيكم العافية.
أهلا.
صوت واضح؟
واضح صوتك، تفضل سيدي.
الشاشة طلعت عندكم أشكو؟
نعم، بس أعملها بس أمور تمام سيدي، تفضل.
تمام.
تمام.
Thank you, Dr. Gandhi. Thank you, Dr. Gandhi, for such nice talk. Thank you for giving me this chance to talk about mid-fracture dislocations, assessment and management. We will talk about mid-foot injuries, dislocations. We will review anatomy, the objectives, review anatomy and biomechanics, outline assessment and management, how to manage mid-foot fracture dislocation. And we will discuss surgical management, whether to do fixation or to do arthrodesis, and we will show some interesting cases. First of all, we will talk about basics. When we talk about the midfoot, we are talking about the junction between the chobot region and the frank region. The chobot joint is composed of talonavicular and calcaneocuboid joint. The frank is the tarso-metatarsal joint. We'll talk about this area. Regarding the biomechanics of the midfoot, first of all, there are multiple arches, the medial longitudinal arch, middle arch, and lateral arch. There are multiple models to explain the complex motions of the midfoot. What we have to concern about here is there are essential joints and non-essential joints. There are some joints with a lot of motion and very important motion, like talonavicular, calcaneocuboid, cuboid metatarsal. These joints, there are a large arc of motion, so we call them essential joints. In these joints, we have to preserve. We will try to preserve in every surgery we do. The medial column, for example, tarsometatarsal and the middle column, relatively they are stiff. There's hardly any motion. They are called non-essential joints. So there is no motion. So we can sacrifice the second tarsometatarsal joint. We can sacrifice the naviculo-cuneiform joint, but we have to preserve talonavicular joint for they are essential joints. When we talk about the chobot joint, which is composed of talonavicular and calcaneocuboid, the talonavicular joint is unique in the body. It has dual relationships. It is part of the midfoot, as we see here, and it's part of the subtalar joint. So it's complex joint combining the midfoot. The subtalar joint is called, or it contains the talocalcaneal and talonavicular joint. Now, another model to explain the foot, which is very important, I advise everyone interested to do foot surgery, especially in pediatrics, to read this model, is the calcaneobedal units, which explain the foot motions and injuries also. The talus is stiff with the tibia. It's called the tibiofibular unit. And the other part, the calcaneum with the cuboid with the other tarsal and metatarsal is called the calcaneobedal unit or the lamina pedis. This point, the lamina pedis or calcaneobedis, calcaneopedal unit move in relation to the tibio-talofibular junction. The combination point here is the interosseous talocalcaneal ligament. The pivot point for the midfoot talonavicular calcaneocuboid is the bifurcate ligament here. It is very important. First, we will talk about subtalar dislocation, which, as we said, involve the talocalcaneal and talonavicular joint. As we see here, in this injury, this ligament should be cut to happen dislocation, like this. This is the interosseous ligament. To do dislocation, this ligament should be cut. It is a 45-year-old male, twisting injury, subtalar dislocation, the whole tail is extruded, closed reduction, stable injury. Now, when we are talking about chopper joint injuries without subtalar joint injuries, the talocalcaneal ligament, the interosseous ligament here is intact. The whole unit of the midfoot, the foot plate rotates either in abduction or adduction in relation to this longitudinal axis. So we have either lateral or medial swivel dislocation. These injuries originally described by this paper very long time ago. This is the classic paper that explain and classify these swivel injuries according to the mechanism of injury with axial load and either adduction or abduction. Later on, further assessment found that if there is axial load with abduction, usually cuboid and lateral part injury. Axial load with medial adduction, there is usually medial injury. But we have to consider in swivel injuries, traction injuries or avulsion injuries in the other part of the foot, especially if it's transligamental. This is why a new anatomic classification classify these injuries whether transligamentous, which is very rare because there are strong ligaments, or transnavicular, transtalar. In general, the distal parts of the joint are more common injured than the proximal part. Almost 50% have combined injuries. So when you see navicular fracture, you have to look to the other side. When you see lateral injury, you have to look to the medial side, not to miss injuries, especially if associated with pure ligamentous injuries. And that's why you have to do stress reviews if you suspect ligamentous injuries. And if you suspect just bone injuries, go for CT scan. Be generous with CT scan for bone lesions. Be generous with stress reviews for ligamentous injuries. We'll start by, this is a swivel injury, medial side, talar head fracture, as we see here. The 33-year-old male medical free patients. Whenever you have dislocation, it's emergency to do reduction. Every dislocation should be reduced temporarily, then plan your definitive surgery. In this case, closed reduction. In swivel dislocations, usually it's unstable. You have to fix it. Unlike subtalar dislocation, usually they reduce, become stable. Now, after reduction, we will plan for definitive surgery. When we do definitive surgery in midfoot surgery, usually we need distraction. We don't have intermittent retractors, so we go with this method described in literature. We use laminar splitter with 2 K-wires, give us good approach for midfoot. Anatomical reduction of the articular surface is very important. To start with, anatomical reduction of the talar head, good distraction, as we see here, fixed with Herbert screw and temporary K-wire. Removal of the K-wire after 6 weeks, keeping the Herbert screw with good functional outcome. Another case, 39-year-old male, twisting injury, multiple subtalar dislocation, which is reduced. We found multiple fracture in the peripheral talus, and as we see here in the calcaneal tuberosity, which is very important, stabilizing for the bifurcate ligament of the midfoot. And addressing this fracture with anatomical reduction, stable fixation with other fracture is very important to stabilize the midfoot. Now we'll go for the navicular. The navicular is very sensitive. First of all, biologically, there is tenuous blood supply in the middle part of it. So there is high risk for avascular necrosis. There's high risk for collapse or non-union in this bone. It's very sensitive. Regarding biomechanics, this bone has compression at the medial side, compression at the lateral side, and also a zone of maximal shear in the middle part. This is why there is high risk for non-union, high risk for avascular necrosis and collapse. This is a case of navicular fracture with tenonavicular dislocation. 36-year-old male, missed injury for 6 weeks. Presented to us like this: still dislocated, collapsed navicular. We discussed the case with the patient, the risk of tenonavicular arthrodesis versus fixation. Then we decide to give him a chance of fixation. Multiple approaches can be used to expose the whole navicular. Then we decided to go for dorsal approach using this method with laminar spreader and K-wire, giving us good approach because there is collapse of the navicular. We decided to do naviculo-cuneiform fusion as far as it is non-essential joints with bone graft, distraction, bone block. We reduce the tenonavicular joint well, put a plate with external fixator. We keep the external fixator for 6 weeks, remove it, then collapse happens again. Complications happen in these fractures. So we remove metal, osteoarthritis, fuse navicular joint. The patient asked for fusion. We did a fusion also, non-union, metal failure. We go for another revision, bone graft again, fixation, till we achieve stable midfoot with reduced arch, pain-free, with satisfying outcome. This is another case, 60-year-old male patient, hypertension, smoker. As we see here, whole subtalar dislocation, talar head fracture, the lateral part of the navicular is comminuted, cuboid is crushed, and the talar dislocated. أبو الأمير الصوت واضح هيك؟ واضح؟
دكتور عبد الله في مشكلة بالصوت.
هيك الو سامعني؟ سامعني؟
كان في مشكلة بالإنترنت كونكشن. نعم.
حاليا
دكتور عبد الله احكي بعد اذنك. حاليا لا الصوت واضح.
حاليا واضح. اكمل.
الان تمام سيدي. الان كمل.
احمد الان تمام. الان تمام. طيب خليني اعيد معناته اخر شيء. تمام هيك سامعني؟
بس تعيد هاي الكيس سيدي. ايوه الكيس هاي بعدين.
خلاص تمام.
نعم.
سامحك.
عبد الله في مشكلة مع الحركة. في مشكلة مع الحركة.
حرك. طيب خلينا اوقف الفيديو.
يعني لما تتحرك حركة بسيطة بتصير في مشكلة.
هيك تمام بدون صح؟
والله لا زالت في مشكلة بالصوت بس ان شاء الله يعني بسيطة تكمل.
طيب احكي على اللوات ان شاء الله.
نفختونا.
ان شاء الله.
36-year-old male, hypertension, smoker, fracture, lateral part of the navicular is comminuted, the keyboard is crushed. Closed reduction was done at another hospital. Also posterior part dislocation, fractures also the tail. Now, closed reduction was done at another hospital with K-wire fixation, temporary fixation of the midfoot. Now we wait till soft tissue settle down. We go for definitive surgery. For definitive surgery, the cuboid is crushed. We start by reducing the length of the lateral column with a bridging plate, reduction of the tenonavicular with K-wire fixation. We put a bone block graft in the cuboid. Then after a while, we remove the K-wire. The cuboid is well, but the tenonavicular is still and unstable talar head and lateral part of the navicular. So we decided to go for tenonavicular arthrodesis, stable foot, pain-free, satisfying outcome with stable fixation of the midfoot. To conclude, care must be taken to address all bony and ligamentous components of the injury, gross dislocations and fracture dislocations must be reduced as early as possible. Surgical treatment aims at joint reconstruction, axial alignment, and restoration of lateral and medial foot columns. شكرا لكم، سامحونا إذا في مشكلة على الصوت.
الله يعطيك العافيه دكتور عبد الله. Thank
الله
you very
يعافيك.
much for this talk. I think this is demanding for any orthopedic surgeon due to the complexity of these injuries and requirement for demanding treatment. Thank you, Dr. Abdullah. The talk now for Dr. محمود عطيوي. دكتور محمود عطيوي اخصائي جراحه العظام في الخدمات الطبيه واخصائي جراحه اورام العظام. He will talk about giant cell tumor of tendon sheath recurrence rate after surgical treatment. دكتور محمود المايك معك، يعطيك العافيه.
سامعني هيك ابو حميد؟
الصوت شويه واطي، مش كثير مسموع.
السكرين واضحه؟
ما في سكرين، لسه مش طالع سكرين على الشاشه.
واضح
عمل شير
أحمد؟
سكرين. دكتور محمود
سامعني؟
تمام،
هيك مبينه؟
هيك مبين الشاشه تمام، تفضل.
يلا بسم الله. Thank you for this opportunity, Dr. Ahmed, Dr. Gandhi. Today I will speak about giant cell tumor of tendon sheath recurrence rate after surgical treatment and our experience in a case series of in Royal Medical Services. First of all, our objectives for today, we will be introducing about the giant cell tumor presentation and radiological examination, modalities of treatment, and results of our case series in RMS. About giant cell tumor of tendon sheath, it's defined as a benign reactive lesion, which is similar to PPNS, pigmented bilionodular synovitis, and it's also named as tenosynovial giant cell tumor. It is a circumcised tumor that does not always arise from the tendon sheath, but may arise from the synovium also. And bear in mind that it is the second most common in hand after ganglion cyst. It's usually a diffuse proliferation of synovial-like cells, giant cells, inflammatory cells, xanthoma cells along the tendon sheath. We should differentiate it from diffuse tenosynovial giant cell tumor, and it usually doesn't metastasize, but the main problem with these tumors are the high risk of recurrence, which reaches up to 44%, starting from 4% in the literature. About the clinical data, it's usually a slow-growing, painless lesion, soft tissue. On examination, it's firm, nodular mass that does not transluminate. It is the second common tumor, as we all said, and it's common on the palmar surface of the radial 3 digits near the DIP joints. It usually affects between the ages 30 and 50, and mostly there's a predilection for female. Our top differential diagnosis for these cases should be clear cell and epithelial sarcomas, fibroma and fibrosarcoma, epithelial inclusion cyst, ganglion cyst, and desmoid tumors. It usually can erode adjacent bone and destroy it, and this has a role in recurrence rate. And hand and wrist, most common locations in about 65 to 89%. Foot and ankle can be present in 5 to 15%, and pressure erosion seen in 15% of cases. Our radiological presentation, we first of all start with plain X-ray. We usually see the soft tissue mass. If there is present any osteoarthritis of the joint or erosion to the bone or the underlying joint, which is seen in 15%, and calcification, which is highly uncommon. Here's a simple X-ray for, we can see the swelling, soft tissue swelling near the bone. About the ultrasound, it can able to determine the relationship of the lesion adjacent to the tendon. It's usually hypoechoic, although some heterogeneity may be seen in echoic texture in a minority of cases. Most have some internal vascularity. The best modality of treatment in diagnosis and pre-surgical planning is the MRI. It's usually demonstrate intense enhancement and iso-intense on T1 and low intermediate on T2. Here's some examples of the MRI presentation. We can see how it's surrounding the tendon and also the bone. And here's also the same MRI. About the pathology of these, usually they are less than 4 centimeters. As we go to the lower limb, they might be more than 4 centimeters. They are circumscribed, often lobulated, and they rarely erode the bone and lose circumscription. Usually they are white to gray. Yellow and brown are common due to xanthoma cells and hemosiderin, and hemosiderin brown color may be present, but typically less than seen with PVNS. Here, how it does look on grossly. And during the surgery, we can see the yellow pigmentation here, and it's usually well circumscribed. About the microscopic, we should specify that usually it have a similar type of nuclei, contains 8 to 10 nuclei and low mitotic activity, and bear in mind there's rarely necrosis and there are no malignant cells found there. About the biological behavior, it rarely involves the skin. It may erode bone infrequently. Malignant transformation has been present in literature, but very rarely, and it's usually not aggressive and does not metastasize. About the recurrence rate, it varies, as we said, from 4 to 44% in all the literature. The recurrence rate is higher under some circumstances, like diffuse or poorly encapsulated lesion, presence of stellate lesion, distal location in the digit, involvement of the extensor and flexor tendon of the joint, intraosseous involvement, and degenerative joint disease. About the treatment, the main goal of treatment is surgical excisions. There are no evidence of other treatment modalities for giant cell tumor of tendon sheath, but as it is a benign condition, we usually stick with a marginal excision. We don't have to take a safety margin, but we will encounter the recurrence still be the single most important issue that preoccupies both the patient and the treating surgeon. About the operative approaches, there's no definite operative approach because it depends on the location and the extent of the tumor. The local recurrence is usually treated with repeat excision, and we can confidently state that the single most important factor to prevent recurrence is the complete surgical excision. Here's a photo of how clinically it appears, and the wound might be as big as this one to remove all the tumor. In our study, we had a group of patients. We did a retrospective study of 40 patients that were operated between 2014 and 2020 for giant cell tumor tendon sheath of the hand and the feet. All cases underwent marginal margin excision, and the mean age was 39. 65% were female. Most common reason for seeking surgical advice was a palpable mass followed by decreased discomfort while moving the joint. The volar side involvement was seen in 57%, with index finger being the most common digit to be involved. Different radiological examination, as we said, we used X-ray, ultrasound, MRIs, but MRI is the gold standard for them. Recurrence was seen in 4 patients, 10% in our series. Paresthesia was seen in 2 patients, and 1 patient had decreased range of motion. The risk of recurrence depends on the surgical margin, size of the lesion, intra-articular involvement, bone involvement, and the histological type of tumor. Here's one of the cases that had a recurrence. As we see here, there's some bone involvement, a huge tumor involving the dorsal and the volar aspect, as seen on the X-ray here and here. Here's the lateral view of the same thumb, and here's the MRI features of the same lesion, and we can see some erosion of the bone and invading the bone and surrounding all the tendon. In this case, we expected to be recurrence because it was also near the neurovascular bundle. To sum things up, giant cell tumor of tendon sheath is a common benign tumor with a good prognosis. Treatment is surgical excision. The big concern for being risk of recurrence that varies in literature from 4 to 44, and in our case series, it was about 10%. Incomplete excision and joint involvement are the two main indication identified risk factors for recurrence. And thank you. Back to you, Dr. Ahmed.
Hello.
سمعت صوت واضح؟
Thank you دكتور محمود، سامعني؟
سامعك دكتور غاندي.
دكتور محمود شكرا لك على هذه المحاضرة وشكرا because it's really good subject to be talk about, sometimes not known by most of the orthopedic surgeon. Thank you دكتور محمود. Now, thank you Sidi. Now our next speaker will be دكتور ناصر الشرع. دكتور ناصر الشرع أخصائي جراحة العظام في الخدمات الطبية الملكية. He will be talking about delirium after neck of femur fracture surgeries. Ready دكتور ناصر؟ دكتور ناصر؟
نعم سيدي.
تفضل سيدي. You can share your screen.
معك سيدي. Okay سيدي. Thank you. مش عارف واضح السلايدات ولا لا؟
لا مش ظاهرة.
مش ظاهر. طيب دقيقة بس.
في شير سكرين.
عملت شير سكرين، بدي احط على دوكيومنت. مش عم بعمل شير الدوكيومنت.
طيب تحب ترتب الامور بتشوف ايش يعني ونرجع لك بعد 10 دقائق؟
دقيقة سيدي.
نعم. يس هاي بلشت. اوكي يور موبايل.
اوكي. هيك واضحة؟
نعم واضح.
اوكي سيدي.
تفضل.
Thank you for this opportunity, sir. Our topic today will be about delirium after neck of femur fracture surgery. My name is Dr. Nasser Fouad Shara. I'm an orthopedic surgery specialist in Royal Medical Services. First of all, we have to have an outline for our subject, starting with the definition, background of this subject, epidemiology, how to diagnose delirium, what are the causes and risk factors, and how to manage. First of all, delirium is a common complication after surgery in the elderly that leads to increased length of stay and other adverse outcomes. We can identify this common problem as acute and fluctuating impairment of cognition, attention, and level of consciousness in the patient. This issue is a multifactorial condition. It is associated and multifactorial conditions. We have this implies many things. First of all, delirium increases the risk of major complications and leads to slow recovery from the surgery and leads to a longer inpatient stay. Mostly, according to many studies, it leads to a 3 days extra for inpatient. It's also associated with being less compliant patient with rehabilitation protocols, and in longer terms, it has a higher association with dementia. First of all, we will start to talk about the epidemiology of this entity. Many studies states that the incidence of delirium post neck-of-femur surgery is about 16 to 18%, and according to the Royal Orthopaedic Hospital NHS Foundation in Birmingham, it was 18%. Many studies showed that older patients are significantly higher, has higher incidence of having dementia, and it is more likely to be associated in female patients more than male patients. Also, many studies clarified that having diagnosis of dementia on the admission is significantly more likely to develop post-operative delirium compared with patients who do not have any cognitive dysfunction on admission. And we ended the thing with that the choice of treatments in neck-of-femur fractures has no significant difference. There were no significant difference between hemiarthroplasty or fixation in developing post-operative delirium. How to diagnose delirium? We can use a criteria which is called the Diagnostic and Statistical Manual, which is characterized by 4 major criteria. First of all, if the patient develops disturbance in the consciousness level and has reduced ability to focus and sustain on some issue or a point. Second thing is if we have a change in cognition, such as memory deficit, disorientation, language disturbance. And third thing, if this entity develops over a short period of time, usually hours to days, this thing has to raise the suspicion of developing delirium in neck-of-femur fracture patients. And the fourth thing, it's a very major thing, that we have to rule out any general medical condition that has a direct physiological consequence in developing delirium. The most important thing is to assess the risk factors which would lead to delirium. If we assess the risk factors, we can raise the suspicion or identify the patients who are at a higher risk of developing delirium more than other patients. First of all, and one of the very important things is the patient is being elderly, which considered in many studies to be above 6 years old, and if the patient is anemic, 10 milligram per deciliter, and a patient and developing a new onset hypoxemia in patient is also a very high risk. Raise the risk of developing delirium. Renal failure and COPD also have high risk of developing this entity. And we have not to forget electrolytes disturbances and imbalances. And also a patient who has been admitted for more than 36 hours has higher risk of developing delirium. And last thing is using general anesthesia more than spinal or local anesthesia has also a higher risk of developing this condition. Okay, we have identified the epidemiology and definition of this condition and assessed the risk factors. How to manage this entity? First of all, we have to identify the patients who are at increased risk of delirium. If we identify the patients with higher risk of delirium, we could, we can, or we are able to mitigate this risk, and we can control this risk by mainly assessing the modification of those risk factors. Risk factors are either modifiable or non-modifiable. For modifiable risk factors, we can control them either mainly pre-op or post-op. For modifiable risk factors such as anemia and hypoxia, those can be prevented to avoid prolonged cerebral hypoxia, which is believed that has a very direct relation with developing delirium. The second thing, if we could avoid general anesthesia, this will be very helpful, and which is according to many studies, which assist that using regional anesthesia and avoiding general anesthesia will be very helpful in decreasing the risk of developing delirium. The last thing is, since this condition is multifactorial condition, addressing a single factor will be unlikely successful to control this effect, and we have to assess many factors to control this condition. And thank you for listening.
Thank you دكتور ناصر، الله يعطيك العافية.
ما فيك سيدي.
احنا يونو انه انت بالدوام واخذنا من وقتك، بس شكرا لك. محاضرة بموضوع مش كثير الناس بتهتم له، هو الديليريوم بوست اوب نيكوفيمال فراكشر. anyway our next speaker، الله يخليك يعطيك العافية. our next speaker will be الدكتور أحمد المقداد. دكتور أحمد المقداد. الدكتور أحمد المقداد رائد طبيب في الخدمات الطبية الملكية، أخصائي جراحة العظام والمفاصل، hand and upper limb surgeon. Dr. Ahmed Al-Maghdad will be talking about corticosteroid injection outcomes in carpal tunnel syndrome. Please proceed, Dr. Ahmed.
يعطيكم العافية مرة ثانية. تمام الأمور هيك؟
تمام.
بسم الله الرحمن الرحيم. I'm going to talk about the corticosteroid injection rule in case of carpal tunnel syndrome. First of all, carpal tunnel syndrome considered the most compressive neuropathy in the body. It accounts for 5% of general population. What do we mean by compressive neuropathy? It is a condition where any nerve can be in the body can be exposed to compression from either pathological or structural tissue. In case of carpal tunnel, the median nerve gets trapped within the carpal tunnel. Now, let us talk about some anatomy. This is the carpal tunnel, where the boundary in the radial side, we have the scaphoid tubercle here, and we have the trapezium bone at the radial side. At the inner side, we have hook of hamate and pisiform. The floor of it composed of a proximal carpal bone, and the roof composed of transverse carpal ligament. Within the carpal tunnel, we have 9 tendons, the flexor digitorum profundus and the flexor digitorum superficialis, as well as the flexor pollicis longus. Also, we have the median nerve within this carpal tunnel. Therefore, in this tunnel, any structural or pathological tissue can cause compression at median nerve. Again, this is the course of median nerve, where we see the distribution, nerve sensory supply of the fingers. We see that the median nerve supply the 3.5 fingers radial side. The another 1.5 fingers, it's supplied by ulnar nerve. Now, let us talk about some causes or causes of carpal tunnel syndrome. The most common cause is idiopathic. Most of cases are idiopathic causes, but we have risk factor and predisposing condition for carpal tunnel, such as diabetes, renal failure, tumors such as ganglion, lipoma within the carpal tunnel, trauma. It is a known entity to have carpal tunnel syndrome post distal radius fracture. It accounts for about 10%. Pregnancy is one of the reversible causes of carpal tunnel. Again, just to demonstrate the distribution of median nerve sensory supply, 3.5 fingers, as we said, and it supply also the dorsal distal fingers of the radial 3.5 fingers. Patient usually present with symptoms. Mainly, they describe pins and numbness and pain during night. They awake frequently and start shaking hand to relieve their symptoms. Also, there is some activities, for example, that lead to provocation of symptoms such as keyboard typing, because this lead to extension of the wrist, which increase intracarpal tunnel pressure. Some patients describe weakness of their grip. We have some provocative tests that can demonstrate the symptom, such as tunnel test, tapping on the median nerve, lead to shooting, paresthesia, and pain within the median nerve distribution. Another thing is Fallon test. Fallon test, because we put the wrist at hyperflexion, this position increase the intercarpal pressure. Therefore, this leads to reproduction of symptoms. In case of a neutral wrist, the pressure within the carpal tunnel is the lowest. In general, carpal tunnel syndrome pressure within the carpal tunnel, it reaches 30 millimeter mercury. In hyperflexion like this or hyperextension, it may reach up to 90 millimeter mercury. Another thing is what we call Durkan test, continuous pressure over median nerve, also reproduce the symptoms. Sensory exam also is important, such as 2-point discrimination, for example, and Siemens-Weinstein monofilament light touch testing. This picture occur in long-standing or chronic carpal tunnel syndrome. This leads to neuropathy, motor neuropathy, as we said here, and there is thinner atrophy, which carry also poor prognostic for carpal tunnel syndrome. Diagnosis in general in case of carpal tunnel is a clinical diagnosis, but we can do objective measures such as nerve conduction study to confirm the diagnosis. In nerve conduction study, as we see, we use a probe that give impulses and we record them. We record it for both motor nerve by abductor pollicis brevis and also for sensory nerves. Usually it is recorded over the middle finger. In case of nerve conduction study, what we record is distal latencies, which is the time from the stimulation till we can record the action potential. In case of carpal tunnel, it is delayed in most cases. Also, the action potential, which is sometimes reduced in case of carpal tunnel. Other objective measure that can we use is ultrasound to see if there is pathological tissue causing compression, such as ganglion or tumor, for example. Let's talk about treatment. The first line treatment is conservative treatment. First line to administer non-steroidal anti-inflammatory drugs. The other line is splinting. Splinting importance that it keeps the wrist at a neutral position, which, as we said before, it is the lowest intercarpal pressure, and usually this is a night splint. In addition to lifestyle modification, we see here in case of keyboard typing, the wrist is in extension like this, so patient can modify some activities to decrease or to avoid position that lead to reproduction of symptoms and signs. About corticosteroid injection. Corticosteroid injection can be given blindly or under ultrasound guided. This is considered invasive non-operative treatment, and it carries diagnostic value, especially in cases of equivocal condition. You know, those patients with carpal tunnel, they have many predisposing conditions such as diabetes, for example, which lead to neuropathy, or rheumatoid arthritis, or secondary to trauma. So patient may have overlap symptoms. Patient who improve on corticosteroid injection, this give you a clue that the diagnosis is carpal tunnel syndrome. Now, patients who fail to improve in corticosteroid injection, this is also carry a poor prognostic factor that those patients will not improve in surgical treatment. Surgery, which is the last line of the treatment, the invasive procedure, can be done either through open technique or arthroscopic technique. In case of open technique, we usually use the mini carpal tunnel approach or the classic approach. In case of arthroscopic technique, it is used through arthroscope. This is minimal invasive procedure, but when we compare both of them together, this is time consuming, more costly compared to low cost and rapid procedure through the open carpal tunnel procedure. Also, risk of recurrence is higher in case of arthroscopic technique. Now about the outcome of steroid injection. Steroid injection in case of carpal tunnel syndrome. This is demonstrate a good prognosis or good outcome in cases of acute carpal tunnel syndrome. Those patients who presented acutely no long-standing symptoms, especially less than 1 year. Some authors mention less than 3 months. They show long-lasting improvement on corticosteroid injection. Symptom duration, as we said, less than 3 months, and there is no associated motor deficit or there is no thinner muscle atrophy. They may show good improvement. Some also compare different corticosteroid modalities of injection. They found the same outcome. We usually give betamethasone injection. And also there is a lot of talk about the platelet-rich plasma, which demonstrate also equivocal effect to corticosteroid injection. As a conclusion, corticosteroid is an effective in short-term cases, especially for mild and moderate compression, this severity according to nerve conduction study, and long-lasting corticosteroid injection show improvement in limited cases, and there is a lot of relapse cases. Thank you very much.
شكرا لك دكتور أحمد. Thank you for this nice talk, which is talking about a very common subject that all of us see in the orthopedic clinic. Thank you very much.
يعطيك العافية دكتور غاندي. الكلام الأخير حاليا للدكتور غاندي. دكتور غاندي كمان رائد طبيب في الخدمات الطبية الملكية، أخصائي جراحة العظام وجراحة الطرف العلوي واليد في مركز التأهيل الملكي. دكتور غاندي يعني أنا بعتبره يعني الصديق والأخ اللي السيرة الذاتية تبعته بكفي إني أشيل اسمه وأحط اسمه مكان حتى تكون ما ينطبق على الدكتور غاندي ينطبق عليه. دكتور غاندي حيحكينا عن الفور كورنر ارثوديسيس using cobra blade.
Grip strength, there was a reduction of the grip strength in the surgery on the hand that underwent surgery is about 30%. What I mean, when we compare the both grip strength, it is weaker 30%. يعني ثلث القوة موجودة post operatively. Otherwise, we can rely in this surgery in case of osteoarthritis in pain and good accepted range of motion. Thank you. دكتور أحمد صوتك مش طالع.
يعطيك العافية دكتور غاندي.
عافيك يعني.
محاضرة جميلة الله يعطيك العافية، خصوصا إنه من الشغل نشتغلوا سوا. نفتح المجال للأسئلة إذا حدا عنده أي سؤال للمحاضرين.
والله يعطيك العافية دكتور أحمد ودكتور غاندي.
العافية.
أهلا وسهلا دكتور.
تفضل.
نعم، بدي أسألك دكتور غاندي، بس أنتوا يعني لما هاي الفور كورنر يعني هل مثلا في بري ريكوست تعمل ام ار اي قبليها نتاكد من الفاسكولاريتي يعني تو دوكيمنت انه في المريض عنده اي في ان لازم يكون عنده، ولا انت بتعتمد على الاوستو ارثرايتس بس؟ يعني هل في داعي انت تعمل له سي تي او ام ار اي قبل العمليه هاي، ولا خلص على الاكس راي مجرد نشخص انه في عنده سناك ريست خلص وي جو فور سكافويدكتومي؟
Thank you for your question, Dr. Maasam Madhoun. You ask about two things, about MRI and CTS. MRI, it's not necessarily to plan our to be pre-requested for the surgery. No, we rely more on the CT and the radiological conventional X-ray, because when we see the non-union, even if there is an avascular necrosis, MRI merely will give us a clue about avascular necrosis or not. Even if there is a avascular necrosis and the patient is complaining of this non-union for more than 2 years, and especially if the patient is a smoker, the results for this surgery, if we do bone graft and fixation, this is the idea. Why to do MRI? There is AVN or not. If this time elapsed from the injury till now less than 2 years, yes, we will proceed for fixation. But if it is more than 2 years, no, we will proceed for salvage procedure, unfortunately.
اوكي، يعني نقطة ثانية كمان، هل بتعتمد بس انت على الاكس راي يعني والاوس يعني اللي نحكي اللي هي ستيج 2 عند 3 ديزيز سناك ريست، ولا بتعتمد برضه على البين البيشنت، يعني المريض يكون عنده اعراض؟ يعني شو المين انديكيشن؟ احنا انت حكيت انه يكون ستيج 2 ستيج 3 ديزيز سناك ريست، بس هل في يعني هل هذا هو السوليد انديكيشن ولا لازم يكون مريض بين وهو
بروسيد؟ يس سوري كمل.
يعني لو ما عمل العملية، هل هذا الإشي يعني it will develop into more severe stage ولا لا؟ يعني شو الفكرة الموضوع؟
We counsel the patient actually when we are talking about this case. When we counsel the patient about the line of treatment. Actually, if the patient didn't underwent surgery for the snack wrist in the stage 2 and 3 after 2 years of the injury, then the natural process, what's documented in the literature, that the patient may take about 8 to 10 years to progress for pan-carpal osteoarthritis. And we inform the patient, if you don't do the surgery, it is expected to have after 8 years a need for total wrist arthrodesis. Then there will be no role neither for proximal row carbectomy, neither for for corner arthrodesis. Actually, in our practice, so many patients, they are refusing the surgery because they are happy with their range of motion. Their pain is not severe. They don't accept the idea of removing the part of their bones and having lose some of their range of motion post-operatively. They will say, okay, I will take the rest. I will not doing the surgery. Incomparable to the patient that they present with pain severe that affecting their life quality and their career, their hobbies. They are asking just to do the surgery, whatever the results are. So we are, before discussing with the patient, our decision based on above mentioned criteria. Then we counsel the patient and put him in the lines of the treatment.
يعني كلام واضح. يعني كأنت كابر لم سيرجن يعني يو ادفايس البيشنت عنده سكافويد نون يونيون انه يعني يفكر بالعمليه، بس انت بتنصحه فيها او لا، ولا ينتظر يعني يشوف هل الناتشرال هيستوري يعني راح يعني ديفينتلي ات ويل جو، ولا انت كرايك انت كابر لم سيرجن يعني شو بتنصح مريض عنده سكافويد نون يونيون وهو بستيج 2 او ستيج 3 ديزيز تو جو فور ذس سيرجري ولا يستنى الناتشرال هيستوري؟
No, to go for the surgery. Because the natural history will be, yes, the natural history will direct the patient to total wrist arthrodesis sooner or later.
أشكرك. تسلم دكتور غاندي.
You know that now there is a rising proximal row carbectomy, and there is a lot of talk about them and comparison between the proximal row carbectomy and four corner arthrodesis. Articles now mention that a patient with proximal row carbectomy show better satisfaction and better range of motion and power, grip power. So even in our practice, we start to shift from proximal row carbectomy to from four corner arthrodesis to proximal row carbectomy, because many cases of arthrodesis, four corner arthrodesis, they still complaining of pain. Sometimes patient satisfaction disappointed for you as a surgeon because they are expecting that they will return to normal range of motion and normal power. They don't understand. So the counseling of patients, you mentioned that this is very important as they don't know the consequences of their surgery, most of them.
Very important question. I have something to mention, but I just mentioned it quickly. What we are going to have in the proximal row carbectomy, we remove all of this bone, then there will be articulation between the capitate in the proximal row carbectomy, not in the surgery, and articulation between the capitate and the lunate fossa. The difference in the curvature of the capitate and lunate fossa, it is quite obvious. What I mean, the diameter of the capitate is smaller than the lunate fossa, so the pressure will be centralized in a specific point rather than all of the fossa. What I mean, the capitate will just digging in central, just like زي المدق زي المهباشة راح تصير الدب. There will be pressure compromised in one central point. The immediate or short-term results of the proximal row carbotomy is quite promising, especially in the procedure that we are doing when we do capsulodesis after removing, as I said, capsular flap. We just fix it to the volar side in this area. When there is a space, we just put the dorsal capsule in the volar capsule, so there will be just a temporary relief point. How much is temporary? It is expected to be within years. Now, to be honest with you, in Royal Medical Services, we are finishing, or we have finished the results about the study of all of the cases that done for coronal arthritis, and we are, as you said, we are shifting to proximal row carbotomy, and we are auditing our job, and we are conducting a study now. It's not finished yet. I cannot give you a solid answer, but we know that this proximal row carbotomy, it is a new era, a new treatment. There is no available long-term results in our hands.
في أسئلة ثانية؟ حد عنده أسئلة؟ دكتور غيث أبو نوار لساتك معنا؟
تفضل دكتور أحمد معاكم.
Dr. Gait, I want to ask about revision cases due to loosening for endoprosthesis. Is it the same like when you are dealing with total hip, for example, or total knee, or there is increased risk in those patients?
This is a great question, dear Dr. Ahmed. Actually, this is a discussion going on in the whole world right now. When to go for revision, what are the symptoms and signs that demand the revision? You have no consensus, actually. What I usually do is I depend on the patient. So after all, we treat patients, we don't treat x-rays or MRIs. Other than the oncological indications, so you need to follow the patient oncologically. Any suspicion of recurrence, you need to intervene. If not surgically, probably medically. But if we're talking about loosening per se, it's the same signs on X-ray, but then again, you have to combine them with the symptoms of the patient. As you know, the revision surgeries for endoprosthesis are quite demanding and challenging. So if you have a broken stem, for example, or a broken endoprosthesis, it's a revision. If you have pain that's not being resolved by any sort of painkillers and the patient cannot tolerate it or live with it, it's revision. And most of the cases, most of the time, you find these symptoms, they are correlated with the signs that we all know on X-rays, loosening signs. So I think it gives you a wider range of spectrum when it comes to revision in endoprosthesis. It's a mega prosthesis after all. I hope this answers your question, Ahmed.
Thank you, sir. Thank you very much. Yes, you answered me. You can press the raise hand on the Zoom application. We have here Dr. Nizar أبو العناس. سامعني نزار؟ Okay, Nizar, unmute yourself, please. Okay, we have a question from Areen Sohail. Unmute yourself, please, and ask your question. Anyone else have any question?
السلام عليكم.
عليكم السلام ورحمة الله. دكتور نزار.
الله يعطيك العافية دكتور أحمد. My question is for you about corticosteroid injection in carpal tunnel syndrome. If you give an injection and your patient's not improving on injection, how long you have to wait before you are doing surgery or open surgery for this patient?
Okay. Now, how long you can wait after corticosteroid injection? This is a topic of controversy. Some people try just 3 weeks with corticosteroid injection and splinting. If they're not improved, they proceed for surgery. In our practice here in Royal Medical Services, we are usually waiting for 3 months. You know that within first week of corticosteroid injection, there is what we call flaring of symptom. Patient comes complaining of severe pain, limitation of movement. This is maybe last for 1 week. Usually we are waiting for 3 months, but this topic have some controversies. Some give just 3 weeks, and some wait for one year, depend on institute.
Okay, Dr. Ahmed, if the patient is not improving on the first injection, do you repeat the injection or no, just single injection and you proceed for surgery?
There is no need to repeat it again. Once the patient not improve on the first injection, there is no need to repeat it. But the question, if the patient, for example, you give him injection a few years ago or a few months ago, and he demonstrates improvement, and then he has relapse of his symptoms, do you repeat the injection or not? In this case, if you have, for example, mild or moderate carpal tunnel syndrome, now you can try another non-operative treatment such as splinting again and also corticosteroid injection. But if the patient, for example, have severe compression since the start, you are proceeding for surgery. Even corticosteroid not mentioned for patient with severe compression. But I try myself for many cases, for example, patient who presented with bilateral carpal tunnel, severe compression on both sides. Sometimes you know that you do the surgery on one side and you give it on the other side. The patient, many patients demonstrated significant improvement even in severe compression. For me, I don't repeat injection if the patient not improved in the first injection, but if they show relapse on their symptoms after a few months. Sometimes you consult the patient about their condition, you know, some they can't do surgery due to their work, due to their social life. They want to postpone it. You can try injection another time.
Thank you, Dr. Ahmed.
You're welcome. Anyone have another question? You can raise hand, please, on the bottom, raise hand on the Zoom. ما في أسئلة؟
دكتور أحمد يعطيك العافية.
الله يعافيك دكتور ناصر.
بدي أسأل الدكتور غاندي. دكتور غاندي, thank you for this excellent presentation. Dr. Ahmed, again, your presentation was excellent. I have a question about the wrist. So if we have a patient that's complaining of wrist pain, and after doing the required examination and tests, we found that he has this degenerative process going on. Of course, age is important. Is there anything that can support the decision of postponing any surgical intervention, and keeping in mind that this will not affect him negatively in the future? Or is it like a resemblance of a knee arthritis, for example, and anyway, it's doomed to happen? And does that affect the challenge of the procedure, the demand intraoperatively?
What I understand from your question, Dr. Ghaith, is that is it a must? Is it a definitive for the patient with the wrist osteoarthritis to go for the if he doesn't do a surgery, he will end up with a need for wrist arthritis? Is this the question? Yeah, let us say the patient
would it be worsened? Is it the
Yes.
same procedure if you postpone the procedure that you have in mind for a wrist arthritis causing? And it's being treated in a way conservatively, there is some relief, but it's still there. The process is ongoing. So if you postpone the surgery, does the surgery differ in its demand, challenge, and or you can risk that in postponing the surgery?
No, the question, the answer for this, as long as we are waiting, we having an osteoarthritis. Having
Yes.
more osteoarthritis, for us, the surgeon doing the four corner arthrodesis or proximal row carbectomy, even if it's delay the surgery and the challenges in the surgery is almost the same. But it is the matter of pain that the patient may have pre-op and post-op. As we said in the proximal row carbectomy, we initiate a new degeneration, a new line of contact between the radius and capitate. The lunate will be excised. In the four corner arthrodesis, the lunate will be also the contact with the radius. Postponing the surgery on conservative, not doing proximal row carbectomy or four corner arthrodesis, most of the time, not all of the time, strikingly, the literature said the patient will end up with pancarpal osteoarthritis. But in the practice, we see a patient for 20 years having snack and doing well, and even discover accidentally when he has just simple trauma to the wrist, and we have, there is a bad X-ray, but the patient is doing well. God knows what's the secret behind that.
Thank you. Thank you very much. Thank you.
دكتور عبد الله خوالده.
نعم.
يعطيك العافية. I have a question for you. Now, in these complex trauma, sometimes you have subtalar arthritis or ankle arthritis. You know, the complaint of patient sometimes ill-defined. And if you want to proceed, for example, with ankle arthrodesis or subtalar arthrodesis or triple arthrodesis, do you do a provocative test or any investigation or examination that to minimize the arthritis, or you are proceeding for triple arthrodesis, for example?
Post-traumatic, you mean?
Yes.
Yes, post-traumatic, if you do examination first, you have to start with weight-bearing X-rays, and you have to assess if you have deformity and malunion. Deformity and malunion should be corrected first. So whether you do arthrodesis or you do osteotomy.
دكتور عبد الله الصوت مش واضح. دكتور عبد الله سامعني؟
في حد من الزملاء عامل انميوت احد الاودينس.
And correction. So you have to do anatomical reduction and restoration.
لطفا دكتور عبد الله، بس بعد انك تعيد الجواب، والجماعه اللي عاملين انميوت بليز انه يعملوا ميوت يور سيلف بليز.
احمد سامعني؟
هلا احكي دكتور عبد الله، هلا سامعينك.
هيك سامعني كويس؟
هيك تمام.
Post-traumatic osteoarthritis, the first thing you have to rule out is deformity. If there is malunion or fractures, it should be corrected. If there is deformity, it should be corrected. You have to do to reduce the arch, the biomechanics, and the axis of the foot. This is very important to start with, whether you do osteotomies for correction or if you want to do arthrodesis. The other thing is you have to do weight-bearing X-rays to assess ligamentous function of the midfoot, of the hindfoot, of the ankle, to assess if there is ligamentous or tendinous deficiency. So you have to restore the biomechanics, bony and ligamentous with each other. Now, regarding osteoarthritis, يعني مش دائما هي cause of pain. If you have ankle osteoarthritis, for example, and you have deformity and you correct it with supramallear osteotomies, with hindfoot alignment, most of the patient complaints will go away without doing arthrodesis. The same thing in the subtalar joint. If you restore height of the calcaneum, for example, if you restore mechanical axis, even with arthritis, patient will do well. The other problem is the midfoot with arthritis, especially the talonavicular joint. It develops arthritis very rapidly because of the high shearing force of it. This is why we go for early arthrodesis. In the mobile column, the lateral column, we will not do arthrodesis. If you do arthrodesis of the lateral column, you have to avoid it. You can't do interposition arthroplasty. You can't do anything else to avoid arthrodesis on the midfoot. Now, if you do triple arthrodesis, for example, in the correct position, plantigrade foot, axis reduction, anatomical reduction of the axis of the foot, if you do it properly, the function will return properly. But even if there is arthritis, if you do arthrodesis with the still presence of deformity, patient will not do it. Especially varus heel or curves of the foot, it will be very rigid foot for function. So the reduction of the axis, the reduction of the shape of the foot is very important to return to normal function. I hope I answered your question.
Thank you, Dr. عبد الله. ضل أسئلة عندنا؟
I think Dr. Ahmed, we are running out of time actually.
أوكي، لقد وصلنا إلى نهاية السيشن. لم يبقى لنا إلا أن نشكركم جميعا محاضرين ومستمعين. الله يعطيكم العافية والصحة جميعا، ونلتقي في لقاء آخر إن شاء الله. يعطيكم العافية. السلام عليكم.
السلام.
يعطيكم العافية دكاترة، يعطيك العافية دكتور أحمد المقداد، الدكتور غاندي، وجميع الأطباء اللي كانوا في سيشن العظام. الآن سوف ننتقل إلى بريك إن شاء الله للساعة 3:30، وبعدها راح يكون في سيشن للENT إن شاء الله.
يعطيك العافية.
يعطيك العافية.
الله يعافيكم.
تم إطلاقه رسميا في خدماته الصحية بعدالة وكفاءة عالية للمواطنين والمقيمين في الأردن دون أي مقابل أو تمييز من الغير المؤمنين صحيا في أي جهة رسمية أو خاصة، ولا يقدرون على دفع تكاليف علاجهم. ويأتي بنك الشفاء والصحة الأردني على غرار بنوك الشفاء الموجودة في عدة دول من العالم، والتي تعمل على تقديم الاحتياجات الأساسية والخاصة في المجال الصحي، وذلك لغير القادرين على توفيرها لأنفسهم ولذويهم، بما يكفل الحفاظ على كرامتهم الإنسانية. ولذلك تم تأسيس بنك الشفاء في الأردن بهدف تقديم الرعاية الصحية الشاملة المجانية للأردنيين والمقيمين على الأراضي الأردنية من الفقراء والمحتاجين الغير قادرين على دفع تكاليف علاجهم. كما يهدف بنك الشفاء إلى ضمان الحد الأدنى للحماية من كافة الأمراض وتعزيز أنماط الحياة الصحية الإيجابية ضمن المعايير الدولية. كما يعمل بنك الشفاء على رفع مستوى الوعي الصحي لدى الأفراد من خلال عقد برامج ومشاريع توعوية وتثقيفية في مختلف المجالات الصحية. ويعمل بنك الشفاء أيضا على رفع قدرات ومهارات العاملين الخدمة الصحية التي يتلقاها الأفراد. ويرفع بنك الشفاء من خلال خدماته التي يقدمها شعاره الذي انطلق منه ويؤمن به، وهو الرعاية الصحية حق للجميع. وقد حقق بنك الشفاء وبفضل الله إنجازات مميزة خلال الأعوام الماضية في مختلف الجوانب التي تعزز منظومة الأمن الصحي في الأردن، حيث يبلغ عدد المستفيدين من خدمات بنك الشفاء بشكل مباشر من أصحاب الحاجة بشكل سنوي حوالي 1500 شخص، موزعون بين مواطنون أردنيون وجنسيات أخرى. وتتوزع الخدمات التي يقدمها بنك الشفاء بين إطلاق الأيام الطبية المجانية وحملات التبرع بالدم وتوزيع المعدات والأدوات الطبية وعقد المحاضرات التوعوية الصحية وإطلاق حملات خيرية، تم من خلال تقديم المعونات من ألبسة وغذاء للفقراء والمحتاجين المسجلين في قوائم بنك الشفاء. ويمتلك بنك الشفاء مركزا للعلاج الطبيعي في لواء الوظيفة يحمل اسم مركز بنك الشفاء للعلاج الطبيعي، تم ترخيصه رسميا حسب الأصول من قبل وزارة الصحة، ويقدم خدماته العلاجية للمحتاجين بشكل مجاني دون مقابل. ومنذ بدء أزمة كورونا في الأردن أخذ بنك الشفاء على عاتقه المساهمة في حماية الأردن والحفاظ عليه من هذه الشائحة التي اجتاحت العالم، فأطلق بنك الشفاء عددا من المبادرات والحملات والبرامج التي تنوعت ما بين التوعية وبين تقديم الخدمات الإنسانية لمختلف أطياف المجتمع الأردني. أدى ذلك إلى أن تشرفت إدارة بنك الشفاء أن كانت حاضرة في لقاء جلالة الملك عبد الله الثاني المعظم حفظه الله ورعاه وسمو ولي العهد مع عدد كبير من المؤسسات التي قدمت جهودا كبيرة وأعمالا استثنائية خلال أزمة كورونا، حيث قدمت إدارة بنك الشفاء ممثلة برئيس الهيئة الإداري السيد أشرف الكيلان خلال اللقاء ملخصا عن أهم البرامج والمبادرات والحملات التي نفذها بنك الشفاء خلال الأزمة. وقع بنك الشفاء عددا من مذكرات التعاون والتفاهم مع عدد من المؤسسات الوطنية والتعليمية، أهمها توقيع مذكرة التعاون مع مجلس الأعيان بهدف تنفيذ برامج صحية وتنموية مشتركة. كما حصل بنك الشفاء على عدد من الدروع التقديرية وكتب الشكر والتقدير من عدد من الجهات الرسمية وغير الرسمية، تقديرا على الجهود التي يبذلها في مجال تحقيق مفهوم الأمن الصحي الأردني. كان أهمها توجيه دولة رئيس مجلس الأعيان فيصل الفايز كتاب شكر لبنك الشفاء الصحة الأردني على الجهود التي يقوم بها في خدمة المجتمع الأردني في مجال الرعاية الصحية وعلى جهوده أيضا خلال أزمة كورونا. بنك الشفاء والصحة الأردني، الرعاية الصحية حق للجميع.